So, hello everyone. My name is Paul Salloway, and I'm from Optics Digital Marketing. And today I'm talking with Adam Barresi, who's at Martin's Eyecare in Glenorchy, just north of Hobart. Hello, Adam. Nice to meet you.
Hello.
Thanks for joining us today. Um, so Adam, tell us a little bit about yourself, like where you're from, how long you've been with Martin's Eyecare, and what are your roles and responsibilities there?
Yeah. So I'm an optometrist, graduating from the University of Melbourne in 2021. I'm originally from Melbourne. Grew up in the northern suburbs. When I graduated from the university, I moved to Mildura in regional Victoria, far northwest. So on the border of New South Wales, about an hour away from South Australia. And there I had a great team around me, some great mentors, a very busy practice where I learned heaps, a lot more there than I would have if I had stayed closer to Melbourne, mainly because there was no permanent ophthalmologists up there. So we had a lot that we needed to do and a lot that we could do within our scope, because patients weren't going to travel to Melbourne or to Adelaide, a 6 hour drive to Melbourne and four
Mm.
and a half, 5 hour drive to Adelaide, um, because we had to be there. We did have some ophthalmologists visiting who came up quite frequently, so we had plenty of access to tertiary eye care, but they were very busy because they only come up every so often. So all the patients around need to get there. So it was a great learning environment that I started my career off with as an early career optometrist. And I was there until September of 2023, where I moved down to Hobart, um, and specifically Glenorchy at Martin's Eyecare. And I've been here ever since. It's been a very busy practice, seen full books pretty much every day, booked out for a couple of weeks. So yeah, definitely been enjoyable from that perspective. Being able to practice to a large extent of my scope. It's a little bit different here than it was in Mildura because we do have permanent ophthalmologists around us and a lot of great ophthalmologists with different niche areas of practice. So that has been an advantage for us, but it has also meant that I'm not necessarily practicing to the same extent that I was in Mildura, but I can still bring in all that knowledge and practice that I was able to do prior to moving here, which has been great.
Fantastic. Well, this is the second of these types of interviews I've done with you guys at Martin's Eye Care. I talked to Martin Robinson, the owner and principal optometrist last year. So Martin's had a pretty diverse background himself. He did some optometry in like regional areas of Queensland with indigenous communities and so on. And you've done some optometry work in challenging areas yourself, haven't you?
Yes, last year I was in Nepal at the start of 2023. And so I was there for a couple of weeks on a volunteer program with Rotary. So it was a joint venture between Rotary Australia and Rotary Nepal, the local groups there. So that's been a program that's been running for about since 2003 thereabouts. Great work from an optometrist in Adelaide who's been running that program. His name's Jason, Jason Booth, and he's been doing incredible work in Nepal for the last 20 odd years. So I met him at a conference in 2022, and from there got involved with that program. So that was quite a humbling experience because the healthcare in Nepal is completely different to healthcare in Australia. Kind of realize how much we take for granted what we have. It's part of the reason that I got into optometry in the first place. I realized how amazing just the idea of vision is. I
Mm.
came up from a neuroscience background, and then from neuroscience, I branched into vision neuroscience, and I was just fascinated by that process. So I realized how much I was taking things for granted, but I didn't realize to the extent at which I was taking things for granted. And it
Mm.
wasn't until I was in Nepal, I'm like, wow, this is just completely different. And it puts a lot of things in perspective when you're practicing in Australia compared to seeing a lot of those patients in Nepal, where the access to healthcare is quite
Mm.
limited
Mm.
and quite challenging. But at the same time, being able to provide that service, uh, quite a rewarding experience. The interesting thing there is, while it's rewarding to do that, at the end of the day, you don't want to have to rely on people like me or some of the colleagues or people like the guys who run this program coming from Australia to places like Nepal. Ideally, we want these countries to have a healthcare system that is self-sustainable, and we can see that in places like I believe Papua New Guinea. There's been some programs there by some amazing optometrists in Australia who now no longer need to go and visit because they're a self-sustainable program. So ideally, we want to get to that sort of situation, but
Sure.
before we get there, being part of that is certainly a rewarding experience for me.
So, and I guess, through that experience, you probably saw a lot of cases um, regrettable vision loss that could have been prevented by, if the resources have been available. And so that maybe is a good segue into what we want to talk about today. So, so to kick things off, I'd like to just preface this discussion by noting that this month that we're in is actually Macular Month. May is designated as Macular Month. So what better time to have a chat about macular disease, and what person to have a chat to about it. So maybe the first one I'd like to ask you about, Adam, is macular degeneration, or what's called AMD, also age-related macular degeneration. So can you tell us, like, what is it? What are some of the symptoms of it, and like how are we treating it these days?
Yeah, so age-related macular degeneration is a specific type of macular degeneration. It's the one we think about the most when we refer to macular degeneration. And an age-related just simply meaning that compared to a juvenile macular degeneration, which is what we'll see in kids. So with age-related macular degeneration, um, one of the biggest risk factors is age. And part of that is because of dietary um, input throughout our life. Part of that is to do with UV exposure. Part of that can be to do with things like smoking. So the longer we live, the more exposed to some of these external factors. But it's not just that. It's also changes that occur naturally that are kind of accelerated. So with macular degeneration, there is a buildup of waste on the inside of the eye behind the macula. And the macula is the center of the back of your eye. So whenever we're looking at something, it's the macula that is directed at what we're looking at and what's doing all the work. So there's a buildup of waste, and normally our body is able to remove that waste. And so there's the buildup and removal, buildup and removal. One of my colleagues put it quite nicely that imagine the garbage disposal is meant to come every week, but is now coming every 2 weeks. Then maybe comes every 3 weeks. That garbage is going to build up. And that's kind of what happens with macular degeneration. We have a buildup of waste behind the macula, or in the macula, but at the back, the outer layers. And so when there's that buildup of waste, eventually we get to a situation where there's blood flow is not able to properly nourish those outer layers of the retina. So we have the blood flow, we have a waste in between, and then we have the outer layers. So if we can't nourish those parts of the eye, then they start to break down and degenerate. This process can take quite a few years to get to some really significant levels. But what we do know is that in the Western world, and so macular degeneration is the leading cause of low vision and blindness. In less developed nations, it's not. We're thinking about things like cataracts and refractive error, but certainly in the Western world, macular degeneration. So in early stages, someone might not actually notice anything because there's no actual change to their vision at that point. Usually the symptoms are going to occur when we start to see something that's a little bit different. So it might be that there's a little bit of blurriness in the central vision. It might be not blurriness, but a bit of distortion. Lines that appear a little bit wavy. The door frame is not quite straight anymore. Those sort of things are potentially symptoms of macular degeneration. They're not exclusively related to macular degeneration. We can get those sort of symptoms with any sort of macular change because the macula is central vision. So if there's some level of distortion to the health of the macula, then those sort of symptoms can occur. But as we get to more advanced levels of macular degeneration, we might notice things like reading becoming a lot more problematic. And that won't be necessarily corrected with glasses. Certainly updating glasses prescriptions will help, but there's a limit to what we can do with glasses there. With macular degeneration, we might look at different types of glasses, or we might look at high-powered reading glasses, or in some cases, low vision aids that can help just to magnify things. And that's really the crux of it. When we have macular degeneration, we can't really, certainly in advanced levels, we can't really define small details. They become quite difficult. And so reading becomes a problem because a lot of reading material is small. So a lot of people with macular degeneration, particularly when it gets more advanced, may benefit more from large print books. And then eventually they won't work so well anymore, and we might have to go to audio books, for example, or low vision aids. But certainly it's something that is a bit of a journey to get to that point. And symptoms aren't always that cut and dry. It's not always a sudden change. Sometimes it's a gradual change, and with gradual changes, our brain can be very good at filling in some of those gaps that may occur. So the best thing to do would really be having regular eye tests, because a regular eye test will allow us to see inside of your eyes, because there's something like close to 1 in 7 Australians over the age of 50 will have some level of macular degeneration. But a lot of those are in the early stages that they won't know. Now, just because you have macular degeneration doesn't mean we have to quickly do something, because it's not always to that extent. And oftentimes we can't do anything because there is no treatment for one of the forms of macular degeneration. So we're looking at environmental factors and modifiable factors, things like diet and exercise, things like smoking, and things like UV protection. Although even in that, there's a bit of nuances. When we get to more advanced stages of macular degeneration, though, things can be a little bit different. And this is really where it depends on genetics. If we have a dry form of macular degeneration, then there is a breakdown of those layers, and we call that geographic atrophy. And so what happens there is that those layers have broken down, and our vision in those parts of the macula just are not providing really good functional information anymore, because they can't, because those layers that have broken down are sending information along a cascade pathway. But if there's a break in that link, then it can't send that information really well. There is no treatment for geographic atrophy or dry macular degeneration. It's all about monitoring. It's all about managing the symptoms as best as we can, managing lifestyle, through a few different things that we can do, such as low vision aids, as best as we can. The other form of macular degeneration we refer to as neovascular macular degeneration, or wet macular degeneration, as some people think of it. And the reason we think of it as wet is because there is bleeding. Neovascularization basically means that there are new blood vessels. When we have new blood vessels, there's going to be a lot of leakage in blood from that, because the eye is not supposed to create new blood vessels later on. When we're developing in our mother's womb, we're supposed to have those blood vessels be new and being formed, but they're just not structurally sound if they're being produced really fast through these age-related macular degeneration changes. So we have all of this bleeding, and there is treatment for that, but it doesn't stop the macular degeneration. It's all about trying to reduce that bleeding and to reduce those continued growth of new blood vessels, and that's with injections inside of the eyes. And so someone who has to have injections inside the eyes would start off by having it quite regularly, potentially once a month for a little while, until things start to stabilize, and maybe extend it out to 1 every 5 weeks, but then maybe every once every 6 weeks, 7 weeks, 8 weeks, until the ophthalmologist believes that the macular degeneration, or at least the bleeding, the neovascularization, is under control and stable. But it is a long journey. There's always work being done into macular degeneration, because it is such a relatively common cause of low vision and blindness in Australia. So there's genetic work that is being done to try and treat the dry form or geographic atrophy and other forms of neovascular macular degeneration. But it's a continued process, and there's a lot that we can still uncover as technology improves and as medicine develops.
All right. Well, as I understand it, like in the advanced forms of AMD, it's sort of the symptoms of it manifested in like a loss of the central part of your vision, whereas the next macular condition that I want to talk about is kind of the opposite of that, which is glaucoma, which I think is more of a loss of the peripheral area of your vision, isn't it? And so, can you tell us a little about glaucoma? Like, what causes it?
Yeah.
Again, what are the symptoms, and
Mm.
how is it treated, and so on?
Yeah. So with glaucoma, it's not inherently a macular disease, although the macula is involved. Glaucoma is much more of a nerve disease. So
Mm,
the optic nerve passes from the back of the eye into the brain, and when that starts to break down, think of that as what's called neuropathy. And so neuropathy is pathology of a nerve, and in this case, it's optic neuropathy. And one of the types of optic neuropathy is glaucoma. So glaucoma is a disease that involves a characteristic uh, pattern of breakdown of the optic nerve. And one of the things that we think of typically with glaucoma is um, tunnel vision. And the reason we think of tunnel vision is because typically, but not always, typically what happens is that there is a loss of peripheral vision. So we start off by having central vision being fine, peripheral vision out here starting to decrease, and then eventually getting to a situation where we may only have our central vision. In advanced cases of glaucoma, however, even central vision will be start to deteriorate. So in the most advanced cases of glaucoma, in end-stage glaucoma, someone will be blind uh, and black blind. I can't say that I've seen that many times in my career so far, even though I am relatively early in my career. However, it has happened into some of the patients that I have seen, but not particularly common. It's usually that we'll see some of the beginning signs of
mm,
peripheral vision starting to decrease.
right.
Having said that, just because someone has glaucoma doesn't mean they can't also have something like macular degeneration. And so then they might have some of the early signs of glaucoma or early signs of visual field loss, I should say, as well as macular degeneration. Glaucoma is a very different sort of disease when you think of that compared to macular degeneration. And the reason for it is because the symptoms typically will occur once the disease has got to quite a relatively severe state.
Mhm,
And the reason for that is that because it's a nerve disease, we have a lot of very small nerves on the inside of the eyes that track around the retina, track around the macula. And if we start to have damage to some of those nerves, then there's a lot of other nerves that can kind of pick up slack, to think of it that way. However, if we get to a situation where we've had a significant nerve damage and a lot of those nerves within that small area have broken down, that's when we're going to have decreased vision. So, what I sometimes say to some of my patients is part of the reason that we want to have regular eye tests is so that way we can pick up on those early signs of glaucoma. Because if we wait to do a test if we wait until you start to notice something is wrong, we could be in a situation where you are no longer able to drive by the time that we
mm,
pick it up, because it can be that advanced before you actually start to notice something, because you have had to have such significant area of vision to have been lost for you to notice it. And by that point, there is so much damage to the optic nerve and the surrounding nerve fibers that track around into the macula, that it's very difficult to really manage that. Well, slow it down for sure, but to reverse that we cannot do currently. So um, it's a very different side of thing. It's a lot more us monitoring, us
mm,
detecting, um, and us finding that
mm,
something seems a little bit strange, investigating that, and realizing, oh, this person has glaucoma. One of the tests that we always do is the eye pressure test. And previously, we used to think that high pressure necessitated glaucoma, but that's not true. About half of people with glaucoma actually have normal eye pressure,
mm,
and not everyone with high eye pressure has glaucoma. Glaucoma is a multifactorial disease. We've got pressure as one of those puzzle pieces, but there are a lot of other puzzle pieces that we need to put together. I've seen quite a few people with high pressure, and we monitor, we do all the tests. They don't have glaucoma, but we consider them a glaucoma suspect. So there's someone who we just want to keep monitoring. Someone with a family history of glaucoma, again, we want to monitor Then maybe a little bit more closely, especially if they've got some of those other puzzle pieces. But once we start to get enough of those puzzle pieces that suggest glaucoma, and we can put them together, and we can say, yes, this person, it looks like they have glaucoma because all of these different factors come into it. And glaucoma is interesting because there are a lot of different factors that we consider when we look at the health of the eye, where we look at the optic nerve, we look at the pressure, we look at the front of the eye. The cornea at the front of the eye is going to give us some really powerful information because it's made of the same material as what's inside of the nerve. We look at the angles at the front of the eye, and when we refer to the angles, that's all about the pressure as well. That is where the fluid from the eye is drained out of the eye. So if those angles are narrow, it's like having a blocked drain pipe in a way. The pressure is going to be increasing because fluid is being produced but not drained out properly. So there's a lot of different factors to consider. And even within glaucoma, there are a number of different types of glaucoma. There's glaucoma that's related to high pressure specifically without any other cause. And there's glaucoma related to high pressure because of something else. So for example, if there is a blockage, a very specific blockage of that angle because of an issue with the iris, for example, which is the colored part of the eye, that's one type of secondary glaucoma. But if it's an issue with another part of the eye that holds the lens together, or holds the lens in place, if that's starting to wear out a little bit, then that's going to cause some blockage. If we have the angle is just getting closed because of other sources, then that's a different type of glaucoma. We can have glaucoma secondary to other things, such as issues with the macula. So someone that has bleeding on the inside of their macula, as I was referring to earlier, when it comes to the neovascularization, some of those growth factors can actually migrate towards the front of the eye and close that angle. And so even then, with certain macular disease, we want to be mindful of this quite severe, aggressive form of glaucoma. It's a very different type of glaucoma, and we don't see that often because usually we're pretty good at stopping it before it gets to that point. But it's certainly something that can occur. We usually think about the more chronic forms of glaucoma, usually the ones that occur over a long period of time rather than the acute sudden changes. The symptoms then, therefore, of the acute sudden changes could be things like intense pain, very blurry eyes, very red eyes. These are typically signs of acute angle closure. So when that angle suddenly closes and the pressure increases many times, manyfold, that doesn't happen as well. I don't see that as often as I do the more chronic forms where pressure is just slowly building up, or if it's not pressure related, then the optic nerve is slowly starting to break down, whether it's because of things to do with blood flow to the eye or blood flow to the optic nerve or otherwise.
Yeah, you mentioned that glaucoma is one of those diseases that can kind of creep up on you without you suspecting it. They even call it the silent thief of sight, don't they?
Yes.
That's the nice little nickname that that particular eye disease has attached to it.
Yeah, and it is because we think of it as silent because you don't notice anything. The central vision is fine. It's one of those things with peripheral vision that we don't always notice, especially when we have two eyes open.
Yeah, and like you said, I guess that sometimes the brain can adjust without us knowing that it's doing that, even though the eyesight's going. So that brings us to another type of eye condition that's different again, and you probably saw a lot of this when you were working in Nepal, because I think it is more prevalent in less developed countries, and that is cataracts. So can you tell us about cataracts? Cataracts are that like white sort of milky effect to the front of the eye, aren't they?
Yes. So behind the iris, we have the lens. And when we're born, this lens is crystal clear, and its function is to focus light. So when we're focusing in and out at different distances, that is the lens expanding and contracting the muscle that controls the lens allows the lens to expand and contract in order to allow us to focus at different distances. Over time, that crystal clear structure starts to become a little bit opaque, becomes a little bit yellow, becomes a little bit opacified in a way. The way I describe it to people is if you leave a piece of clear plastic out in the sun, that will start to go a little bit yellow. And that's kind of what happens to the lens, because one of the biggest factors for that is UV radiation and a lifetime's accumulation of UV radiation. So what that means is if you live long enough, you will get a cataract.
Mm.
It's pretty simple as that. Even if you wear sunglasses all the time, even if you're very careful with UV protection, you're still going to get a cataract. However, UV protection, of course, is important because we can delay the onset of those cataracts. The oldest person I've ever referred for cataract surgery was 95 years old.
Wow.
I saw someone a couple of weeks ago who was about 92, and his lenses were still in really good condition and only a little bit yellow. He still had excellent vision. The youngest person I've ever referred for cataract surgery was in their 50s, I want to say. Um, Now, there are different types of cataracts. It's not all just a yellowing and kind of like a filter appearance. We have sometimes more aggressive types of cataracts that are a bit more fast developing. The fastest cataract I've ever seen, I saw someone in November or December of one year, and she had very, very early signs of these fast growing cataracts. By the time we got to about March, her vision had deteriorated to about a half to a quarter of what she was when I saw her in December, or November, December. I referred her to a surgeon, and she saw the surgeon less than a month after I referred her, and her vision had halved again from when I had seen her the second time. That's very uncommon to see it progress that fast. But she had a very aggressive type of cataract. Those types of cataracts are a little bit different because they start at the very center of the back of the lens, and that is where a lot of that light is really focused through. So if a cataract is more diffuse,
Mm.
what we'll have is kind of like looking for it through a filter, where light is not coming through that lens as clearly, as crisply as ideally it should, and the light is kind of diffracted out. And we start to get some of those, maybe a little bit of halos. It might be that contrast is a little bit down, so people will start relying on light um, and bright lights to help with their reading. Oftentimes, someone will say to me, "Yep, I can't read the paper, but if I go outside and I angle it just right, I can read the paper." And it's just because a lot of that light is allowed and easy to see. With those more aggressive forms of cataract, it's just smack bang right in the, and it can make things very difficult. There's then other types of cataracts that start on the outside and gradually work their way in, like little spokes of a tire, just gradually working their way in. When I was in Nepal, I saw some of the most advanced cataracts that I will probably ever see. Um, Part of the reason for that is access to healthcare. And so a lot of these people have what we would consider um, pretty, moderate to severe cases of cataracts. And for them, we couldn't refer them for surgery because people had much more severe cataracts that had to be triaged and prioritized. And in those advanced cases, that's when we really see that milky white appearance or the brown appearances. I think I can count on one hand how many of those I've seen in Australia, whereas I could count on one hand how many I'm seeing in a couple of hours while I was in Nepal.
Mm.
So it's chalk and cheese. But with cataracts, most of the time they're very slow growing. You could take decades to get to a point of needing to do anything. Just because you've had cataract when you're 55 doesn't mean you need to do anything about it. Could be in your 80s potentially by the time we need to actually do something about those cataracts. So a lot of the time they are just really slow growing. All we do is monitor. We don't need to touch them. There are three reasons that I generally refer people for cataract surgery. One is if they're preventing me from being able to perform a proper eye examination, and that would be that if I can't see inside of your eye properly because the cataract is making it hard for me to inside of your eyes, and I'm worried about something, maybe you have diabetes and I want to check for diabetes damage, and I can't see it properly, maybe you have some other sort of eye disease that I can't monitor properly, that's a good reason for us to try and to refer. Equally, if that cataract is causing damage at the front of the eyes, where it can be leading to increased eye pressure and then following on to things like glaucoma, that's another good reason why we might want to refer. Another reason we might send someone away for cataract surgery if they can no longer drive or they're getting pretty close to their driving limits. Cataracts can be quite socially disruptive because it can really impede on someone's independence if
Mm.
they aren't able to drive anymore, or maybe they're getting so much glare at night that they can no longer drive at night and that limits some of their social activities. Um, so that's a discussion I often have with patients when they have those sort of cataracts, and is it affecting their functional life,
Mm.
um, regardless of whether they drive or not? Because sometimes someone doesn't care about whether they can legally drive or not because they've never driven, and so we're not going to have to consider that. But maybe it's affecting them because they can't go out at night. Usually, their husband or their wife or their partner will take them out. Maybe it's not got anything to do with that. Maybe it's that they can no longer read properly regardless of the life. Maybe they're having trouble doing some of their hobbies that they've been doing for so many years, and that can become quite debilitating for some people, um, depending on how it's affecting them. So that would be the third reason then that I often send people away for cataract surgery. Um, and when I say sending them away for cataract surgery, what I mean is that we refer to have a discussion with the ophthalmologist um, about having cataract surgery, because not everyone needs cataract surgery. Just because, as I said, just because you have cataracts doesn't mean you need it. Some people, especially earlier on in my career, I was over referring people for cataract surgery, I think. Um, they had what I thought was significant cataracts. They'll go see the ophthalmologist, they'll have the discussion with the ophthalmologist, and they'll decide, they're functionally fine. They don't Driving doesn't matter to them because they don't drive. They're able to do all their activities. We're still able to get a good enough look inside of their eye. It's not causing any damage. And so for those cases, we don't necessarily need to perform cataract surgery. Having said that, there are some people who would prefer just to have the cataract surgery because it might mean that there's less dependence on their glasses, and that might be a convenient factor for them. That's a little bit complicated because there's a little bit that goes into that, but um, you know, there's a lot of different factors. But I think the moral of that, or the key message there, is just because you have cataract surgery, just because you have cataracts, doesn't mean we need to do it.
Mm.
But there are, similar with macular degeneration, there are environmental factors that always play into this. Something like smoking. Smoking increases the risk of a lot of different eye diseases, such as macular degeneration, such as cataracts, such as increasing the risk of something like diabetic retinopathy. And so the smoking is something that is a modifiable risk factor. UV radiation, as I mentioned, everyone will get a cataract at some point. If we can protect our eyes with really good quality sunglasses, then that's going to go a long way in reducing that accumulated exposure and prolonging the onset of those cataracts. Not
Mm.
stopping them, not reversing them, but prolonging the onset.
Well, you touched on a topic that I want to talk about next, and so if we think of cataracts as, for want of a better word, poor countries' problem, there's a disease I think that's becoming widespread in more developed societies, which is diabetes, isn't it? I mean, diabetes is just an epidemic proportion now. So I can assume from that diabetic retinopathy is something also that's becoming more and more of a challenge in terms of managing people's eye health. So can you tell us a little more about, like, what is diabetic retinopathy and how can we address it?
So diabetic retinopathy, I have the discussion with pretty much all of my patients with diabetes because most of them don't always know why they're coming to see me. They don't always know what it is that I'm doing. They know that, yeah, I've got diabetes, it can affect my eyes. And it's true, it can affect your eyes. But I like to have this discussion with patients because I like to allow them to understand their diabetes, because at the end of the day, when we're looking inside of someone's eyes and trying to assess for diabetic retinopathy, we're not just doing it for someone's eyes. We're getting a good window into overall cardiovascular health.
Mm.
And what I mean by that, if someone has diabetes, then their ability to regulate the level of sugar inside of their blood is not as well controlled as it ideally should be. And so what happens is that our body either cannot produce insulin, or it does produce insulin that the body doesn't respond to that well. And insulin is really important at taking that sugar out of the blood and storing it. And so if our body can't do that, whether because it doesn't produce insulin or it doesn't respond to the insulin, those blood sugar levels will rise. And then or the other way to think of it is they don't decrease at a rate that is healthy. And so when we have a sugary meal, those blood sugar levels rise, and then normally they would come down. The problem with our blood sugar levels being elevated, especially elevated for a long time, is that can cause damage to the inside of blood vessels, particularly the small blood vessels in the capillaries. When they start to get damaged from the inside, eventually they will start to leak, and they can start to become deformed. Things, when I say deformed, I'm talking about something called a microaneurysm. And so there's a weak outpouching of those capillaries or small blood vessels. And then they can also start to bleed. And we think of those as hemorrhages, or dot hemorrhages is what we refer to them, or blot hemorrhages if they're a little bit larger, but they're small hemorrhages, they're small bleeds. When I'm looking inside somebody's eye, I'm seeing those small blood vessels. And the blood vessels inside someone's eye are the only blood vessels inside of the body that we can see with non-invasive techniques. I just need a microscope. For someone with diabetes, I'll always try and put dilating eye drops in, so they dilate the pupils, so it's a lot easier to see inside of the eyes, and so it's a lot easier to see those blood vessels. And so when I said earlier that it's like a window into someone's cardiovascular health, it's just that I can see your blood vessels inside of your eyes, and if they're really healthy, they're probably on the healthier side throughout the body. But if they're leaking and they're bleeding, and I see a lot of different hemorrhages and microaneurysms, that's probably happening throughout your body. Now, I'm not going to change your medications for diabetes. I'm not going to look to do anything like that. But what I'm going to do is I'm going to write a letter to the doctor and say, this is what's going on. This is what the level of health is inside of this person's eye. The second part of that then is, well, it's inside of the eye. What does that mean? And when you have diabetic retinopathy, or your blood vessels are starting to leak and bleed, that can cause some vision changes. It can cause vision loss in some more advanced cases. And it's because those blood vessels are unhealthy, they're causing damage to the surrounding areas, there's leakage, those parts of the macula start to become, in some ways, they can become deformed. And it can cause similar sorts of symptoms to macular degeneration in a way, in which case things can be a little bit distorted, things can be a little bit blurry, but it's different to macular degeneration because the mechanism is different. But those sort of symptoms can be similar. With that diabetic retinopathy, depending on the severity of it, we either can or can't do something. So when we have more advanced retinopathy and there's a lot of bleeding, or there's active neovascularization, so active production of new blood vessels, that is when we will send someone to the hospital or send someone to an ophthalmologist, or an ophthalmologist in any case, to try and treat that. And they'll be treating that with injections inside the eyes. Anti-VEGF is what we refer to it as, and that is to try and decrease that neovascularization, decrease the production of new blood vessels, decrease that active bleeding. In advanced cases of diabetic retinopathy that does not have that active bleeding, we refer to that as non-proliferative. Proliferation just meaning the production of new blood vessels. So in non-proliferative diabetic retinopathy, most of the time we're just going to monitor. And depending on the severity will depend on how frequently we monitor. So in more advanced cases of non-proliferation or non-proliferative diabetic retinopathy, we might be monitoring every 3 months. In less advanced, maybe it's only every 12 months. What we do know is that the rate of diabetic retinopathy is much, much higher in Indigenous and Torres Strait Islander Australians compared to non-Indigenous Australians. And I think it is something like 6 times more likely in someone of an Indigenous Australian. So the guidelines that we work around when it comes to diabetic retinopathy suggests that we monitor someone who has of an Indigenous background a lot more frequently, just because of that much higher risk. Of course, it's still relatively high in non-Indigenous Australians, but it's much higher in Indigenous Australians.
I've heard that there are actually some other ethnic communities where diabetic retinopathy has a higher incidence, like some Asian communities, for example, seem to have a lot of incidence of diabetes in general.
Yeah, and a lot of it, part of that is to do with genetic underlying factors. Part of that is to do with environmental factors. And environmental factors include things like diet, um, or alcohol abuse or alcohol use. So sometimes it's cultural as well, depending on someone's upbringing or someone's environment. There are a lot of different factors that do go into that. Yeah.
Okay, so you mentioned that so that when you're doing an eye exam, it's like you're a window into someone's cardiovascular
Mm,
situation. Um, Tell us about like hypertension, high blood pressure. Like how does that
yeah.
something also that you can detect through an eye exam, and maybe maybe as an early warning signal that there are deeper health issues at
Yeah.
play.
So just like with diabetes, where the blood vessels inside of the eyes can be affected um, through a systemic disease, it's the same thing with something like systemic hypertension or high blood pressure. If someone has high blood pressure, then that will manifest, and we can see that in all parts of the body. And as the blood vessels inside of the eyes are the only ones that we can see non-invasively, then we can see certain changes. And some of those changes might be the appearance of those blood vessels. So there may not be any bleeding, but those blood vessels start to change the way they appear. So they might become um, they might start to press on each other, for example. So if I
Mm,
have if I have an artery and I have a vein underneath that artery, and this artery starts to thicken, it's going to push against that
mm,
vein.
mm,
And if that occurs, then we're going to see characteristic changes when we look inside of your eyes, because we're going to see that that is pressing. We're going to see that the shape of that vein changes that little
mm,
bit because it's being pressed on. If we have a look at other blood vessels that are not pressing on it, we might see that they've become a lot straighter, or in, um, because the walls are thickening in there, and there are changes that are occurring to those blood vessels. In more advanced cases, we can see that there will be some leakage or some bleeding. Typically, don't see that as much as we do as with someone with diabetic retinopathy, but I've certainly seen some people that have had that bleeding associated with high blood pressure. And it's a different type of bleeding to diabetic retinopathy, because the blood vessels that are bleeding are different. And so the bleeding looks a little bit different. In some cases, we can have occlusions of those blood vessels. So something called a vein occlusion. I actually saw two yesterday, where someone's vein had been occluded, and there was a whole heap of hemorrhaging and bleeding all around that vein. And the reason that occurs is because when the artery is pushing on that vein, that blood flow doesn't really move. And so we have what's called stasis. And so
mm,
stasis means that that blood is not moving, it's pretty
mm,
still. And when that happens and there's not that blood flow, which there should be, then similar to diabetic retinopathy, we will have damage to the inside of those blood vessels. And part of that is because of oxygen just not being able to be transferred because it's not moving.
mm,
So when we have damage to those blood vessels and we're due to an occlusion, then there's going to be a lot of bleeding as a result, because that blood vessel is not working so well. So in some cases, that can occur to what we call the central retinal vein. And if it occurs to the central retinal vein, then that is going to pretty much affect all of the veins inside of it. And we will see hemorrhaging and bleeding everywhere. If it occurs to a smaller subsection, so a branch, we would refer to that as a branch retinal vein occlusion. And so it's not affecting everywhere, but it might only affect a certain vein. That is where the crossing is. So it depends where that crossing is. It depends where that artery is pressing. This is not exactly hypertensive retinopathy, but it is a type of retinopathy that can be secondary to these hypertensive changes, because a vein occlusion is secondary to something to do with the artery. arteries. And so the arteries will change their shape, change their caliber, their thickness with something like high blood pressure, something like high cholesterol, and what we refer to as atherosclerosis or arteriosclerosis. It's a different entity. And these sort of changes we can detect. And ideally, we want to detect them before they get to that sort of level where they are actively bleeding, or bleeding first and then actively bleeding if not controlled. Unfortunately, we can't always detect that ahead of time because sometimes the symptoms just aren't there. So the two people that I saw yesterday came in and saw me, and they had no issues whatsoever when they came in. When they sat down, they were not concerned at all by their vision. They were happy with their vision. There was no issues with peripheral vision. There was no issues with central vision. Everything was fine, and it was more of an incidental finding that I had found. So, oh, there's a whole heap of blood here. And you investigate that further, and you work out why they have this bleeding. So what we like to do is ideally detect those small changes, detect those little changes in the blood vessels, the little nicking, is what we refer to, nicking of those blood vessels. And if we see those, that's when we need to have a discussion about blood pressure or cholesterol, as the case might be in different situations. And so often what I would do is I'll write a letter to the doctor, and I'll say, look, this person has come in and seen me. This is what I have found. This is most likely because of blood pressure being elevated. In a lot of the cases where I see that, someone is already under the care of their doctor. They're already taking their blood pressure medications. They measure their blood pressure, and they know they are now in a pretty safe range. And so in those cases, I'm less concerned. I'm more concerned with the people who had no idea. Those people who have high blood pressure without realizing it, those people who haven't been to the doctor, or the doctor's been monitoring it, but the patient's been reluctant to start some medications, which is completely fair enough. But then when we start to see these changes, that's when we might need to have a discussion about, well, maybe we need to start doing something. Or sometimes it's just to realize that this is now a driving factor to go and see the doctor. There's plenty of people I see who haven't seen their doctor for a long time because nothing's been wrong until we find something like this.
Right. So that's really like a key takeaway for me from this discussion and discussions like this, that it really having regular eye exams are so important, not just to detect like earlier macular conditions, early eye problems, but also just general health problems like diabetes, like high blood pressure. So yeah, so like your eye care professional can be like the early warning sentry for a lot of serious health concerns down the track.
Absolutely. I've seen multiple people who have had a stroke inside of the eye. If you have a stroke inside the eye, you're pretty close to having a stroke. I have seen someone only a few weeks ago who would have had a stroke at some point in her brain, but it was to an extent where she didn't realize she had a stroke. And then I did a vision check and realized that she was missing exactly half of her vision, which would have most likely would have occurred from a stroke given her history, which I'm not going to go into. So yeah, certainly there are these things. I had someone only a couple of weeks ago who had an eye test in 8 years, and she came in and she had a whole heap of bleeding inside of her eyes that was not to do with macular degeneration, not to do with blood pressure, not to do with diabetic retinopathy. And I had to send her straight to the hospital, and she needed injections in her eyes that day. So, one thing I always tell my patients, especially when everything is going really well, especially when their vision is perfect and their eye health is perfect, make sure you keep coming back for eye tests, because if there are those early signs, we're going to pick up on them. And if we pick up on them, we can either do something about it or we know to monitor it, rather than just letting things fall by the wayside. Because sometimes by the time you notice something's wrong, it's either too late, or we've got a huge barrier to climb.
Yeah. So I guess like the couple of questions I have to wrap up here. So like we've talked about a lot of very serious eye conditions today. So if I went in for like a standard eye exam, a standard eye
Mm.
checkup at just a, like a standard, I don't know what it is, 20, 25-minute checkup, would that type of eye test reveal any of the things that we've talked about today, like, macular degeneration, glaucoma, cataracts? Would that
Yeah.
normally be the case, or would you have to do something more? Would you have to actually request a more comprehensive exam because, you explicitly want to check for these things?
So generally speaking, you don't need to request uh, a specific exam. That initial consultation is generally enough for us to either detect, diagnose, and start management,
Mm,
or give us enough clues for us to then initiate to do further testing. Specifically, that's especially the case with something like glaucoma. Because glaucoma has so many different puzzle pieces,
mm,
oftentimes we'll get quite a few puzzle pieces done in that first consultation, and they will give us enough of a hint to say, I think something's going on here. Let's do some further testing. And that's when we'll bring someone back and do some further examinations. If we do those further examinations all the time, routinely, then that's a lot of it can lead to some issues. Something like a visual fields test, for example. We will always do a visual fields test with someone with glaucoma, and anyone who has glaucoma or suspicious glaucoma will know how much they probably dislike having a visual fields test done. But we wouldn't do it routinely because someone might dislike it. We wouldn't do Part of the reason we wouldn't do it routinely is because it takes time. Another part of the reason is it costs Medicare money, and we're not going to unnecessarily charge Medicare. We're not going to unnecessarily put someone through that, or put ourselves through that as well. So we kind of do a lot of these tests on indication. We see something's wrong. We have a family history. Any of these puzzle pieces, we'll go and do further testing. With
mm,
something like macular degeneration or diabetic retinopathy, or some of these hypertensive changes, oftentimes it's a lot easier for us to detect that if we put in dilating eye drops. And sometimes we can do that in that appointment. Sometimes we need to bring someone back or have a slightly longer appointment, depending on how large someone's pupil is. If the pupil is really large and I can see perfectly inside, I can tell you have macular degeneration without doing further tests. I will still do further tests to further reveal the extent of that macular degeneration, make sure nothing else is going on underneath that we don't want to miss out on. Um, but doing those further tests is not something you would need to request specifically with most optometry practices, especially if the optometrist is doing a thorough eye exam, not just of someone's vision and glasses prescription, but of the eye health. And so for me, my order of operation when I'm with a patient almost always is, once we've gone through those questions, once we go through those screening tests at the start, I will look at your eye under a microscope before I start checking your glasses.
mm,
Because if I see something like all that bleeding, I'm not going to worry about trying to update your reading glasses if I need to send you to the hospital, as I needed to do for that patient that I had recently. So um, for me, I'm always very mindful of that. There's no correct way. You don't have to do that before you do classes, for example. That's just the way I do it. But my priority is always eye health, and I will either detect something or realize that something might need a little bit further investigation.
mm. Okay. So the last question, I guess, is like, how often should people have eye exams? And I guess that a lot of that depends on your risk profile,
Mm,
and your lifestyle and so on, but also age, I guess, is an
yeah.
important component of your risk profile. So like, if you were to give some general advice about like how frequently people should get eye exams depending on
Mm.
their age, what would you say to that?
It's really tricky. As you said, there's a lot of factors like risk factors. Someone with a strong family history of eye disease, even if they don't have it, should be monitored a lot more frequently than someone who is perfectly fine at that point in time and has absolutely no family history of eye disease of the same age. So there's no single correct answer to that. I often will review people with a family history in the absence of any eye disease for themselves, specifically maybe every 12 months. But if they're completely fine, maybe it's every 2 years, depending on their age, maybe it's every 3 years. Other people, I will monitor every 6 months or every 3 months. It really depends. What I would say is that if you haven't had an eye test in 2 years, you should probably think about booking in with your optometrist. If it's been 3 years, then you should definitely book in with your optometrist. And if you have a family history of eye disease, or you've been monitored for some sort of suspicion of eye disease, such as glaucoma, um, then if it's been more than a year, most of the time we should probably be booking in for another eye test. Or diabetes, if you have diabetes, even if there hasn't been any diabetes damage and it's been more than a year, let's think about having another eye test. Yeah, the best way to answer that question is on an individual basis and having that discussion with your optometrist to factor in your age, factor in your risk profile based on your family history and your health at that time.
So even if you've got 20/20 vision, there's still a lot of very good reasons to get in and see your optometrist regularly, right?
Absolutely. 20/20 vision is only one very small part of our vision.
Yeah. Well, all right. Well, thanks, Adam. This has been like an absolute goldmine of information, and I hope everyone's got a lot of value out of what you've told us about these different types of macular conditions and eye health conditions. So if somebody hasn't had an eye exam for a while, or they're just concerned about their eyes, so how can they get in touch with you at Martin's Eyecare? What's the procedure?
Well, easiest way is to give us a call. You'll find us online. We have our website active. But giving us a call, have a chat with us over the phone, or come into the clinic and we can have a chat. We're always happy to take on new patients, and see everyone who wants to see us, because we want to see you.
All right. Okay. Well, thanks very much, Adam. It's been an absolute pleasure, and thanks for your time.
Thank you.